Hi, my name is Coral Hawking and this is my Therex final practical video. And the first thing that we're going to do is treat a patient with primary shoulder impingement. Now, the primary impairment here is going to be a lack of abduction range of motion, and I'm going to choose to do a GlenoHumeral inferior or caudal glide. So I'm going to come over to my patient here where I have her supine and scooted towards me, and the first thing I'm going to do is pick up her arm and have it in kind of a resting position and put it in between my arm and my trunk, and I'm going to get her relaxed here, and we're going to relax, there you go, and I'm going to I'm going to hold it in between my arm and my trunk. I'm going to put one hand in the axilla space, and I'm going to palpate for her acromion so I can get that joint line, and I'm going to put the web space in that joint line and provide a grade 1 distraction and make sure my forearm is placed good here. And what we're going to do is do a grade 3 joint mobilization because the object here is to increase range of motion. So we're going to go ahead and do that. So the dosing here is going to be 6 to 8 seconds 3 times. After the first time, we're going to assess for irritability and see if we need to make any adjustments from there. So the next patient we're going to see is presenting with Patellofemoral Pain Syndrome, and a common impairment that we see in these patients is going to be weakness in the quadriceps. So I'm going to choose to do the technique of a manually resisted exercise for knee extension in order to facilitate quadriceps strengthening. So I'm going to come over to my patient here who I have sitting on the most appropriately height stool that I could find, and I'm going to go ahead and place a towel rolled up underneath of his distal femur and place that good there. I'm going to go ahead and have him hold on to the counter in order to stabilize his trunk, and I'm going to go ahead and bend down because of the height of the stool, place my web space over his distal femur, and I'm going to go ahead and walk him through the range of motion first so he knows what to expect. Then I'm going to ask him to go ahead and go through that motion by himself. Awesome. And now I want you to go ahead and push into my hand. Ready? Push, 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 and then hold, 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 bring it down slow, bring it down slow, bring it down slow, bring it down slow, bring it down slow. Awesome. So we demonstrated a concentric, isometric, and eccentric manually resisted exercise, and in order to dose for this, I'm going to do 3 sets of 10 reps of that kind of concentric to eccentric progression there, and after the first rep, we are going to assess for irritability and see if we need to change anything or progress as appropriate. So the next patient we're going to see is status post rotator cuff tear, and a commonly injured muscle with the rotator cuff is the supraspinatus, whose primary action is abduction. So in order to assess and target an impairment with the rotator cuff, I'm going to do a range of motion for abduction, and I'm not sure what stage of recovery that we're in, so if it's acute, I would go with passive range of motion because the active range of motion is contraindicated, and that's what I'm going to demonstrate on my patient over here. So we're going to come over and I'm going to have my patient supine and scooted towards me, and the first thing that I'm going to do is put her in 90 degrees of flexion to kind of for her comfort, and I'm going to have one hand on the back of the dorsum of her hand and one hand on the underneath of her elbow, and I'm going to provide external rotation because of that scapulohumeral rhythm to make sure that I can get the full range of motion here, and I'm going to kind of get into a good stance here, and I'm going to take her through the range of motion and back. So the dosing here is going to be 3 sets, 10 reps, and after the first set, we're going to assess for irritability and kind of see if we need to make adjustments and progress from there. So our next patient is presenting with a neural mobility impairment in the lower extremity, where the primary impairment is going to be the mobility of the nerve. So I'm going to choose to do a straight leg raise flosser. So I'm going to start with my patient supine, and we need a surface to prop his leg on. So in this case, we're going to use a pool table. So I'm going to go ahead and bend down and I'm going to put his involved leg propped up on that surface and go ahead and have him relax there and make sure that he's straight. So go ahead and scoot this way a little bit. Awesome. Yeah, there we go. So what we're going to do is I'm going to start by having him dorsiflex his ankle, and I'm going to come and grab his head, and we're going to plantar flex and flex his neck, and then come back. Plantar flex and flex his neck, and then come back. And we're gonna do this for 3 sets of 10 reps. After that first rep, we're gonna assess for irritability to see if we need to progress the patient from there, if they're having bad symptoms, or just kind of see what we need to do. And then that should conclude my Therex practical video. Have a great day, Dr. Henny.